This module will provide an in-service for the iGel O2 Airway. The module is broken up into several pieces. Participants will need to complete each section, take a short unit quiz, and the final exam. Participants must score 85% in the final exam in order to pass, and you must have completed this module prior to using the iGel O2 Airway. Course objectives. First thing we want to do is provide an introduction to the iGel O2 Airway. We want to describe its use, and talk about airway management and maintenance related to the iGel O2 Airway, and we want to identify clinical indicators for the use of that iGel Airway. An introduction to the iGel O2. The iGel O2 Airway is a supraglottic device. It's got a soft gel-like non-inflatable cuff, and it's designed to provide an anatomical impression fit over that laryngeal inlet. We'll look at some general features of the iGel O2 Airway. We'll start at the top. There's a built-in hook ring, helps fasten a securing strap. The securing strap comes with the airway. This eliminates the need for a third-party tube securer, such as the Thomas tube tie. The important part of this airway is that non-inflatable cuff. We think that removing of inflatable cuffs on there will potentially reduce the amount of damage that may occur to the airway during insertion. We know that the hazard of airways like the Combi tube or the King airway is occasionally the cuffs can get ruptured either on dentition or other foreign bodies in the airway during the insertion process. The iGel O2 does have a gastric channel for suctioning. It's not as large as on some other airways, but we think it'll still help reduce air in the stomach and potentially decrease the amount of vomit we see during a cardiac arrest. It does have an integrated bite block towards the top. Again, that eliminates the need for that Thomas tube holder. The iGel Airway has a passive oxygenation port built into it. At this time, we're not going to be utilizing that feature, but we need to make sure that the cap is secured and it's maintained, as that tube connects into the main lumen of the airway and is subject to those airway pressures. So leaks past that cap could significantly degrade our ability to ventilate the patient, especially if the cap comes off completely. A review of that anatomy. Again, the open view showing the pharynx. We're hinged backward at the nasopharynx line. Now, iGel is flexible. It's actually designed to be inserted running off of that hard palate and deflecting around the back of the oropharynx. Once it's advanced all the way into its place, it should seat against that laryngeal framework. You see that standard insertion would come down. The tip of the iGel would be lodged in the esophagus. There is an esophageal port. We can do some suctioning there, reduce stomach contacts as needed. So just a lateral picture of that, the final positioning of the airway once it's inserted. You notice the tip of the airway seats in the esophageal opening. It does have the suctioning port there. The cuff should be located over the glottic opening and up against the laryngeal framework, and the incisors resting against the integral bite block.